Welcome to the Medical Matrix podcast. I'm your host, Dr. Rosie Sender. I'm an orthopedic surgeon and I specialize in hand and upper extremity. Medicine has overlaps with multiple scientific and business communities, yet there are disconnects in our understanding of our respective fields. The aim of the podcast is to talk to experts in medicine, business, and technology about emerging innovations, contemporaneous and/or controversial topics. This will enable a better understanding of our respective contributions to the issue of interest, as well as opening the door for more open collaboration between medicine and allied industries. Welcome to the Medical Matrix. I'm your host, Dr. Rosie Sender, and I have Dr. Erica Fisk with me here today. Erica is a board-certified orthopedic surgeon, and she specializes in foot and ankle surgery. And our guest today is Dr. Justin Barad. He's the founder and CEO of OSSO VR, and he's an orthopedic surgeon, and he went to medical school at the David Geffen School of Medicine and did his residency in orthopedics at UCLA. He also did a pediatric orthopedic surgery fellowship at Boston Children's Hospital. So virtual reality has had a rapid growth in many different industries and organizations. And this is including the military, engineering, construction, education. And it's actually most commonly known by people from the gaming industry. But it's also grown in the medical and healthcare space, and we'll be focusing on that in today's episode. I wanted to go over the different types of reality platforms because we'll be throwing out some terminology. And so just so that people have a basic understanding of each of these reality platforms, I'll give a brief synopsis on each one. So virtual reality is a fully immersive experience, and the user ends up leaving the real world and they enter a fully digital environment. And this is through virtual reality headsets. Our brains believe that we're moving amongst the objects on the screen. And some of the examples that are out there for virtual reality are Google Cardboard, the Samsung Gear VR, and Google Daydream. They have a smartphone app that creates the VR experience. The Oculus Go and Oculus Rift, however, are standalone virtual reality headsets. Another type of reality platform that is also in existence and talked about frequently is augmented reality. Now, that's an experience where virtual objects are superimposed onto the real-world environment. And this is through the use of smartphones, tablets, augmented reality glasses. The best example is probably Pokemon Go, that whole craze. And mixed reality is the last platform that I want to mention. And it's a platform that's going beyond augmented reality. It's where virtual objects are placed in a real world environment, and they can be interacted with and respond as if they were real objects. A mixed reality headset is used, and they offer a holographic or immersive experience through translucent glasses. And an example of this technology is the Microsoft HoloLens or the Samsung Odyssey. So it's that gesture, it's that gaze, it's that voice recognition technology through a pair of motion controllers or through a mixed reality headset that helps deliver a believable mixed reality experience. Actually, the company Ford uses it to prototype future vehicles instead of doing it in the physical environment. Welcome, Justin. Thank you for joining us today.
Thanks for having me.
So our episode today is on the use of virtual reality in surgical teaching, and that's why we brought Justin on, so that he can help guide us through what's happening in that area of technology and just go into how he's contributing to it. So Justin, why don't you tell us a little bit about your company?
Yeah, I'm happy to. So, what OSSO VR is an anytime, anywhere surgical training and assessment platform. So you use this VR headset here to immerse yourself in a virtual operating room, and you could train on literally any procedure using your hands realistically like you would in a real operating room. It also incorporates assessment, so you can get objective feedback on your performance and allows you to train as a team. So all of us, being surgeons, can jump into an operating room remotely, even though we're not physically in the same location. As I always say, surgery is a team sport, not an individual sport, so you should train as you practice. OSSO VR is currently utilized in 20 countries around the world. where we have simulations mainly in orthopedics right now, and joint replacement, pediatrics, trauma, and spine. And we're also branching out into vascular surgery, thoracic surgery, and the general robotic space as well.
Okay. What was your inspiration to start the company?
Well, brace yourselves. It's a bit of a long story.
Well, that's what we're here for, as a podcast.
Let's go back to middle school, where we all start these things.
Okay.
So, I've been a huge fan of video games my entire life, and I was really interested in how they were made. And so I decided pretty early in life that I wanted to make video games and be a video game developer. So, I taught myself how to program and kind of was really on this computer science game development track. I even had the opportunity to work at a company called Activision, which is a huge video game publisher, and I have a game credit with them. I was really excited about this, if it's not coming across. And then my life took a bit of a left turn. I'm sure, it's funny reading the personal statements of people applying to come into orthopedic surgery, because usually there's a story of an athletic injury or something like that. I didn't necessarily have that exact story, but it was a personal experience with medicine that got me interested. And what happened for me, a family member just got very ill and was hospitalized for the majority of my senior year. And I wondered to myself, I thought, I love software and technology so much. Is there a way to use it not necessarily to entertain people, but actually help people, especially ones with medical problems? So I discovered this new major that I hadn't known about called bioengineering or biomedical engineering, where you can use engineering principles to solve healthcare problems. I'm like, oh, this is exactly what I want to do. So I pivoted from computer science to bioengineering at Cal, which was great. And my goal in my mind was, I'm going to get this degree, and then I'm going to be this inventor and invent all these different technologies that's going to help people and solve all sorts of problems. Hooray, everyone's awesome. And so as I neared graduation, I was waiting for the moment where someone would be like, hey, here's how you do all those things. And that wasn't really anywhere clear to me. So I started kind of panicking near senior year of college, as I think most people do. And so also doing something that most people do is getting breakfast with my mom's gastroenterologist. I'm sure we've all had this moment.
Of course.
And I was chatting with him. He's asking me what I want to do. I told him. And he said, if you want to invent something, you need to understand the problem you're trying to solve first. And he felt that the best way to solve or understand medical problems was to be a physician. So, I took his advice super literally, and he helped me get into medical school at UCLA. And I loved it. Go Bruins and go Bears. I love them all. And then, I stayed to do orthopedics because, for me, it was really a great fit because I could apply engineering principles to help people. So it really appealed to me. And also, I'm sure everybody in this room, for people that don't know what orthopedic surgery is, it feels like magic. And, you take someone who can't walk and, they're up and walking again. And I ended up going into pediatric orthopedics for a couple of reasons. One is I kind of had a feeling that adult medicine had become I love it, but a bit coin operated, that there was a little too much money and business involved. And I was really attracted to the mission-driven nature of helping children. I really like the idea of everybody just in it to help the kids. They really don't care how much money they make, much to their detriment, and anything else, or how many hours they're awake. It's all about helping kids, and I found that to be really attractive and exciting. And I mean, the moment that really hammered it home, I was walking into a clinic, and there was this kid who had flown from another country, who was born with untreated club feet. You guys know what this is, and 14 or 16. We did a triple arthrodesis, is a salvage procedure. But as I was walking in to clinic, I could just see him out of the corner of my eyes grabbing, and he was going, Dad, that's the doctor who made it so I could walk again. So I just
your heart
went into
probably
the
goes
went in the bathroom, cried, and you can't show weakness, so nobody saw that. But I decided I was going to do peds ortho because there's nothing really more rewarding than that. And so all of this is happening, and I'm trying to learn how to do surgery. I'm watching surgery. I'm in surgery every day, and I think every surgeon's worst fear, at least when they're in training, is that they're going to graduate undertrained or not able to do a great job. And I was a little, uncomfortable with the way that we were learning to do surgery, which is mainly just sort of watching it. But it really felt quite random to me on one hand, where you're sort of a victim of chance where, for example, one of my co-residents on his hand rotation, which you, Dr. Rosie, can relate to, had 0 distal radius fractures for 2 months. Just total random fluke. But that's something that you really need to know how to do in any practice, and so we're getting to the point where there's so many different procedures and ways to do them that you're not able to get exposed to it all, was one thing that I noticed. Another issue is the increasing complexity of the procedures that we're doing. So, during certain procedures where we'd be trying to use a new technology or maybe a device that we don't use very often, instead of helping with the procedure itself, people would be like, hey, Justin, go scrub out and help the rep Google the technique guide or a YouTube video or a Vumedi video. And I'm sure people have this experience. And it's, most surgeries are safe, and surgeons are amazing, but it happened enough times that I was kind of raising an eyebrow. And I think for me, the thing that really hit home is that there's just no objective assessment at all, really, of our surgical skills, which is, I think for me, when I was a resident, it was very stressful to not know where I was and to really only go by kind of how much people liked you. It was really how they're rating or giving you the ability to do surgery. There was one time in my career up to this point that I had been assessed. I was interviewing for residency, and this guy pulls out the board game Operation, puts it on the table, and asks me to remove the funny bone without buzzing. Oh. And I kind of laughed, and he wasn't laughing, so I'm like, oh, are you serious? I still don't know if that was a serious activity or not. I mean, I did it, and I was super proud, and I heard some people turned it upside down and shook the pieces out, or stories like that.
I thought this was a rumor because I had heard about this when I was doing my residency interviews. So it actually does happen. It actually happens.
Yeah, no, I mean, I have some crazy interview stories for you guys. That's just the tip of the iceberg. Okay. But in retrospect, I'm happy he did that, right? I mean, I just got hired. I still take peds trauma call on the weekends, and nobody had any idea if it was safe for me to operate or not. They're just, looking at where I trained and making an assumption. Well, he's probably safe. And, if you listen to the podcast Dr. Death, which, I would like to point out to anybody listening to this that that guy was a neurosurgeon, not an orthopedic surgeon.
An ortho would never do that.
Never.
But, you could definitely, I think every doctor I know who listens to that podcast or that story says to themselves, or they say to me, I know somebody like that, and they just got through. Yeah. And it's not their fault, and it's not, saying anything on them, but it's just, you need to know if it's safe or not to fly a plane, right? Yet we don't have this for doing surgery. The one thing I always point out to people is, when you get on a plane, you're not furiously Googling your pilot to make sure that he's safe, or calling your grandma to see how her experience was with that specific pilot, right? The things we do when we're getting surgery are crazy, and you don't do these things when you get on a plane because most likely you're going to get the same result every single time. But the reason why you're furiously Googling and calling people is that there's a lot of variability, and so you're worried, and not for it's for good reason. And so these were things that I was feeling, and I was kind of curious, what does the data show? And so when I looked into it, I was actually really taken aback. And I think most people in our field are they have a general sense that some of these things are going on, but I don't think they have a sense of the actual numbers, which is super alarming. So, one of the landmark studies in the field of kind of surgical assessment, surgical skill, is in the New England Journal of Medicine from 2013 from Birkmeyer et al. And this was a study in bariatric surgery, so very different from what we do, but I think you can kind of extrapolate out and make some common sense assumptions based off of it. And what it found is that when you look at videos of low-skilled surgeons and higher-skilled surgeons, and then look how those patients did, what they found was for the higher-skilled surgeon, every single patient did better in terms of their hospital length of stay, readmissions, complications, and their morbidity and mortality. And one of the takeaways from that study that was very alarming is that the mortality rate was 5 times higher for the lower skilled surgeons than the higher skilled surgeons. So, if there was some sort of factor that would increase your likelihood of dying from surgery by 5, you would probably want to know about that so that you can do something about it, right? It's not like you're just going to fire these surgeons hey, maybe you should get better at this one procedure. It's not a reflection of you as a person. So that was a really big landmark study where people are like, hey, maybe we should start looking more at the skill of the people doing the procedures rather than looking back on how people did after the procedures, because it's really too late to do something about it at that point. Another big study was something from Brian George in the University of Michigan in 2017 in the Annals of Surgery. And this answered a pretty basic question: is how good are we doing at training surgeons? So it's a very long road to become a surgeon, as you guys all too well know. It's 4 years of college, maybe you did a research year, but another 4 years of med school, and then maybe take a gap year again. And then it's, God knows, 5 to 7 years of residency, and then some form of fellowship pretty much across the board, like so many fellowships now, right? And so in this study, they looked at a bunch of things. One of the things they looked at is, how autonomously can graduating residents operate? How much supervision do they need after 14 years of education? And what they found was that 31% of graduating residents still couldn't operate on their own. And you guys know, I mean, we all know that's true, right? That's part of why we're doing fellowships, is we need additional training. So, the problem is very simple at its core. It's too much to learn. We're the victims of our own success. There's too many procedures, too many technologies, too many devices to be able to learn with traditional educational paradigms. The second is that the procedures themselves are exponentially more complicated than they used to be. Learning curves for a traditional arthroplasty, maybe 10 to 20 cases. For anterior total hip, 50 to 100 cases, right? Robotic arthroplasty, navigation, patient-specific implants. These things really expand and lengthen the learning curve. And the final component is the lack of assessment. So I'm experiencing all of these things, and I'm still very much involved in the world of gaming. And so, the second I tried VR, I'm like, oh my God, this is going to solve this problem. You can practice any procedure. You can practice it as many times as you need to. You can actually practice on the pathology you'll be treating. For example, like in a cadaver lab, which is sort of the gold standard right now, if we wanted to practice, doing a scoliosis or deformity procedure, that cadaver is not going to have scoliosis, right? So even the gold standard that we have, you can't really practice certain techniques. You can get objective assessment, and then the big issue once again is like train as a team. We actually at UCLA they did a study where they looked at how many people are actually in the operating room at any given time and what's the variability. And what they found for a single spine surgeon, on average there were 8 people in the room at any given time, and over a month, 25 different surgical techs and 51 different anesthesiologists. And so that's another big issue that we have. Like, it's, you're working with somebody, like an entirely different team, like every single day. And that team might have no idea what surgery you're doing or anything about it. You could be working with the B or the C team who are like super specialized and they're great at whatever they do, but they're not familiar with your field, if you're working at night or on the weekend, which is all too common now. So, I basically came up with this idea in between residency and fellowship, finished fellowship at Boston Children's, come out to Stanford to do their Biodesign Innovation Fellowship, which is an amazing program. And then, I had met some guy on the internet in an Oculus
sounding
forum.
sketchy right now.
Yeah, no, this is where things take like a hard left and then get really interesting. So yeah, I meet this guy. He's like looking for work in serious VR. And I'm like, well, I have this like prototype I can show you. So I showed him like what I built, and he told me that I was the least crazy person that reached out to him.
Oh, wow.
Makes me feel good.
Ringing endorsement. So, we agreed to work together. I had some money I had set aside from my bar mitzvah. So I used that to pay him. Thank you, Grandma and Grandpa. Okay. And, we built this prototype that we submitted to a conference, the Graphics Technology Conference, GTC, and we won an award. So that was really exciting, and all of a sudden, like, investors started reaching out, and this is when virtual reality was like very exciting and hot. Like, VR is still exciting, but it's still kind of in the trough of disillusionment. Right. So like people are just like, here, take my money, and I'm like, what's going on? Like, I had to like starting like buying books on Amazon. I'm like, what? I don't even know what words they're telling me. And so I had this opportunity where I'm like, I could go full time with this stranger I met on the internet who, lives somewhere I'd only met one time. And, I jumped out of his moving car at one point to pick up a cable we needed for an investor meeting.
Sounds so much like Silicon Valley.
I know, totally.
I know this story. It's called Silicon Valley. It's a show.
Episode 111?
That show is like way too close to home. Yeah. So, like I'm on the path, right? We're all on that path where, you do this, ABC, you're a doctor forever and everyone's super happy. Or I could take this huge risk on something I was really passionate about. And so I was kind of at this crossroads where I could stay at Stanford and do the program, or I would have to drop out of Stanford and go full time with OSSO, which would have some potential implication for my career as a surgeon. I might never operate again. I didn't know. And so, I called like my parents and my friends to see, what I should do. And they were all like, do not drop out of Stanford, 100%. It's a terrible life decision. But I thought back on a fellowship interview I had at Sick Kids. And, I sat down, it was with like the chair, the program director, I can't remember. He like opened my packet and closed it like after like 10 seconds, and he goes, clearly you're a bit different than our normal applicant. So yeah. I'm not even going to ask you any questions. I'm just going to give you some advice. And, this is like, breakfast with my gastroenterologist part 2, I guess.
Yeah.
And so he's like, don't worry about what you think success is. Don't try and find it. Just do what you're passionate about and success will find you. Trust me. And I was like, that's the weirdest interview I've ever had, second to being asked to play Operation. And so in this moment, I thought of that. I'm like, well, this is what I'm passionate about. And I thought of another thing. In college, I was involved in like the Greek leadership system. And, we did this sort of like, kind of team building activity called the tap of leadership. And so everybody's on the ground. You have your eyes closed and you can't stand up until someone taps you on the shoulder. And then when someone taps you, you can tap other people. And at the end of the exercise, they ask, will the person who got tapped first raise your hand? So some guy raises his hand and they ask everybody in the room who thinks that like instructor 1 tapped this guy, and like half raises their hand. And then they say, who thinks it was instructor number 2? And it's like the other half. And then they're like, will the person who tapped themselves, or they asked that person and said, who tapped you? And the guy said, I did. And to me, that really blew my mind, because I was all ready to sit there for hours, and it didn't even cross my mind that I could just tap myself on the head and stand up and start tapping other people. And this is like this transformational realization I had in a whole life where all you're doing is jumping through hoops and getting degrees and trying to seek the approval of others. This is a path where the only person who can give you permission to do this is yourself. There's not some special degree or special thing that's suddenly going to give you the ability to do this. And so it was those two experiences combined where I walked into the director's office at Stanford and I said, I'm dropping out. And like, I mean, his jaw fell to the floor. It was, not a pleasant conversation. I think I hit like an ambulance on my way out. I was not doing well either.
Oh, no.
And, 2 days later, I'm in a Starbucks by myself with some guy I met on the internet. And I was like, here we go.
Yeah. And,
today we're, 43 people. Like I said, we're used in 20 countries. We train thousands of surgeons a month. And the technology works. We've done 2 clinical validation studies that show anywhere from 230 to 300% boost in surgical performance. And this one at UCLA, they compared individuals who trained with OSSO to individuals trained traditionally, and found that the performance scores of the OSSO VR trained group improved by 230 points. So most people at this point are like, you made a great decision, good job. But I would say that was not a path I'd recommend to most people. I think there's probably a way to, my hope and my goal and my excitement about talking to you guys and being on this podcast is there is a way to make innovation more of a part of mainstream medicine, where it's not this thing that you have to blow up your whole life and take a huge risk to do, and that it's something that you can train for longitudinally, because a lot like surgery, it's a lifelong discipline, and that you have the opportunity to participate in a way that doesn't require you to completely exit the world of medicine, so that we both can benefit from each other. And so that's what I want to talk to you guys about.
Okay. Well, I'm so glad that you're able to talk, because I completely believe in that. I've kind of taken a year for myself where I'm working part-time. So I'm working on some other projects, which are a little bit too much in their infancy to talk about completely yet, but I've tried the Oculus. So I'm a big fan of virtual reality. I wasn't doing anything educational at all. I was playing a game. I think it was Beat Saber or something akin to that.
It's a good one.
It was super fun, but just the technology blew me away. So when I saw that, your company was doing that with surgical education, I was like, oh my gosh, I wish we had this when we were training. It's such an innovative way to augment our education, right? Especially like you said, there are times where you're not necessarily going to be on a rotation and see the kind of case you need to see or get enough cases in. So I'm really glad you took the risk and, met that guy on the internet and just...
His name is Matt. Hi, Matt.
I have a lot of comments in general, but I think it's cool that you can standardize some type of surgical training because it's so variable. I had 2 of my own co-residents from Ohio State training that were actually held back, but they were done so in a really subjective way that they didn't understand. They were held back a year because they didn't feel, or the authorities and large, they decided that they were not fit yet to graduate and operate on people by themselves. And to have like an objective way to move through a surgical residency that's standardized, where I'm not getting more surgical exposure because my chief resident has done 100 of these and now he feels comfortable that I can operate and oversee me, where if I had had a different person, maybe I wouldn't have gotten that hands-on experience. And so I feel very fortunate to have gotten that experience, but in the same sense, in the same residency program, I have had my co-residents who did not get the similar experience, and they were kind of not punished, I would say, but they were held back until they felt it was appropriate for them to continue on. And I guess it's interesting the training as a team type of mentality with your system is that you're in there and can you get objective feedback right then and there? So it's not like you make a critical error. It's like, wah, life's over, start again. Like, do you have like certain lives? Is it like a video game in that sense? Or like, do you get that, hey, like, don't cut there, here's, someone taking you through that virtual experience to show you in the same way that it's done in surgery. We're like, okay, put your retractor here. This is what you don't want to get into. This is the next step. Here's the trick. And you have that immediate feedback and interaction. Is that...
Mm-hmm. Yeah, I mean, there's a lot to unpack there. I think you had a lot of great points. Digging into assessment first, we handle this a few different ways. One is that for certain critical steps, there's a range of what's acceptable clinically. And so, you always want people to improve, but if it's okay, right? If your hip's not perfectly center, perfect is the enemy of good. You can do better next time, but let's move on. So we'll give people that feedback that it's like, it wasn't perfect, but here's how you can improve next time. And then certain things are not okay. So, if you put a screw in the joint or in somewhere where it really shouldn't be, you probably shouldn't be allowed to proceed because you want to make sure that someone understands where that's supposed to go. And so, usually we'll have like a practice mode where you can make whatever mistakes you want, go back and forth, retry as many times, and then assessment mode where it's like kind of more, if you do run into one of those failure states, then you do kind of have to go back and kind of just make sure that you have an acceptable performance. And then, there's also this delayed feedback has been shown in some studies to be more effective. So we give certain feedback within VR and then certain feedback afterwards so you can review your performance. And when we think about assessment, what does that even mean? There's so many different surgical scoring systems. So we kind of had to like create our own, to be honest. And so we really think about like 3 key things. The first is knowledge of steps. At the end of the day, like surgery is like cooking or construction or baking. It's like, if you follow the steps, most times it's going to turn out okay. And then you need to know how to troubleshoot when things don't go as planned or if you make some sort of mistake. And so the foundational thing is just knowing the steps and having them, known by heart. And it's like, this is clearly, I think, something that is probably one of the most undervalued aspects of surgical training that we don't emphasize enough, that if you have the steps of a procedure fully memorized, you're going to be much more successful. Like, I don't know if you guys have seen this, but I've worked with surgeons who print out the steps and like tape it up in the operating room, right? And it probably means that they don't know it super well, right? So you should know these steps super well for a procedure, and there's certain technologies that will also remind you, like when you're in the procedure. So like even some musicians, if they have a piece fully memorized, they might still have the music in front of them just in case, The second part is doing those steps well. So certain steps are really conducive to training in VR, and so we want to focus in on those and make sure that people understand how to do them well. If we can give feedback on how to do certain things better, we want to do that. We don't want to get too caught up in all of the nitty gritty, because certain things don't translate super well from VR. So you have to really be careful on like what steps you want those to be, where you really want to emphasize them in terms of making sure that people are accurate. And then the final component is really efficiency, is that if someone is able to move very smoothly through a procedure, there's a lot of literature in the simulation research that shows that they're more likely to be successful in real life, that there's evidence of skill transfer. So those are some of the areas that we really focus our assessment around. And, typically we'll walk someone through what we call the happy path of a procedure. So it's like, hey, let's just work on the foundation first. Everything goes great, nothing goes wrong. Now, I know none of us have been in a surgery probably where things go completely as planned, including my playlist always seems to be on like the wrong Spotify or Pandora channel, which is, I think, the most critical element.
Oh my gosh. Or like
it was like, who put Madonna on?
I know. Or yeah, a song comes on where you're sort of like, oh no, I don't want people to know that this is on my list.
Yeah. No, I mean, that's awesome. It's kind of interesting, but or a playlist can be controversial, so you do have to be careful there. But
100%.
I do enjoy the occasional punny song like No Scrubs or Smooth Operator.
Yeah.
So you get the happy path down, and then it's like, all right, now you have the basics. Now you want to focus on what I call like skills, concepts, and troubleshooting. So, you want to understand how to balance a knee, right? Like if it's tighten extension, tighten flexion, or, what to do if you take off too much tibia, or like what to do for, if you have too much ligamentous laxity. So just as an example. So, start working through like, okay, here's how to get out of a variety of situations. Then people were like, well, how do you introduce complications? Are they random? And, that's kind of like a fun thing, but, sometimes you want to be pretty intentional about what you're doing. So, we have the option to practice complications on purpose, be like, I want to do like a complication scenario where I want to understand that better. We're working on artificial intelligence to basically introduce complications at random. And then also a facilitator could also introduce them as well. So like, you could be in with me showing me how to do a bunionectomy, and, I don't know what happens. The big toe fall off. I don't know a lot about it. It's been a while. I just pin elbows now. So, those are some of the things we think about. Some other things that you brought up, though, that got my mind spinning. There are two kind of, I would say, this pretty controversial area where we're kind of playing in, so you have to be careful. But issues on the front end and the back end of your surgical career. So on the front end, when you're a medical student, I think one thing that we can do, I'm really excited about, is idea of career exploration. Like one of the biggest challenges in medical school is deciding what fields you want to go into, right? And especially in orthopedics, you sometimes get none or only a week. So it's not really enough to make a huge life decision on. And I feel like if we can expose people to actual orthopedic procedures sooner, maybe they'll get more excited about it, and also can optimize their applications for getting an orthopedic, since it's so competitive and you have to start doing research really early. So it's like by the time you're doing your orthopedics rotation, it's kind of too late to make that decision. So it's this kind of difficult situation. So I'm really excited about providing this for career exploration, and even before med school, like for college and high school kids. And we actually have an event with the Department of Education every year where, high school and middle school students try OSSO, and every single one's like, I want to be a surgeon. And I think, to me, it's like really important that so my mom, she just had me and my brother. So I always felt like I need to like represent her and women, because she was like a really major leader for women's rights. And in orthopedics in particular, it's like in 2014, something like 4% of orthopedic attendings were women. And I think there was some research out of Penn that showed that if you had more women exposed to orthopedics earlier, they're more likely to apply and subsequently get in. So I'm hoping that this may move the needle a little bit on what is a really major issue in our field. I mean, that is just like ridiculously lopsided.
Yeah, I'd like to add a little bit to that too. During my residency, I was the only female. And they hadn't had any female before me actually graduate. And, there was like a few that had dropped out. And what was interesting was that, and I'm petite, I'm pretty small. I'm not the classic representation of what you consider an orthopedic surgeon, right? And
hand surgeon.
I also did a trauma
No comment.
fellowship. I also did a trauma
Okay, there you
fellowship,
go.
so I'm legit.
She's a badass. We all know this.
Okay. But what was interesting was that we had medical students, like females, that would come through, and they were like, "Oh, I didn't know I could do this. I was always told that this place, like orthopedics, isn't for women. That women can't become orthopedic surgeons. We're too small. We're not." And I'm like, I'm 5'2". I weigh 100 pounds. Like, if I can do this, you can do this. Like, it's not, you might have to be smarter, and, you're using more brain than brawn, but you can certainly do it. So I think introducing people to this earlier and saying, yeah, this is what this field involves, and going through the process, going through the procedure gives you a better idea of whether it's something that is a good fit for you. And the other thing that I thought about when you were talking about making the decision on which field you're going to go into, there were times where I feel people were making decisions based on how good their rotation was or who they worked with versus the actual specialty itself. Right. Do you know what I mean? Like,
oh yeah, no, I mean, it's so true. It's just like, yeah, who you get along with, really.
Who you get along with and stuff. And so, I think exposing people early on to the realities of what the profession is crucial, so that you can, help you pick the right profession, especially when you're committing as much time as you're committing, all the hours you're putting into your residency and your fellowship, and then later on in your life, right? And so a higher retention rate overall, ultimately.
Yeah.
What was the program exactly in Stanford that you dropped out of?
We're gonna put you on blast right now. So
just forget that. No, I'm just curious.
First of all, I highly recommend it for anybody that's interested in medical innovation, whether you're a physician or an engineer. It's called biodesign. It's actually really unique. It kind of revolutionized the way we think about healthcare innovation, where the one part of the really unique approach was, taking engineers and physicians and putting them on teams together to solve problems. And the other approach was what's called need-based innovation. And so this is very similar to, what my mentor Henry told me way back when, where it's, let's not create technology and then try and find interesting applications. Let's find a big problem in healthcare and then ideate around that. And they have a whole process by which you can kind of systematize innovation in a way to sort of provide a bit of method to the madness. So there's a lot of materials. You can get the textbook online. There's a whole video curriculum. There are executive programs for clinicians who don't have a huge amount of time, or if you're a resident or fellow, you can apply to be in it. But I'm a huge proponent. And then UCLA recently started its own biodesign program as well. And there's one at TMC now. So they're popping up all over the place, and it's really it's an amazing phenomenon.
Is it like a 1-year program or 2?
Yeah, so the classic fellowship is 10 months, but they have I think a 1 to 2 week executive program as well, and program for undergrads even. It's really pretty cool.
Okay. It seems like there's a lot of availability and exposure to PhD, like MD, PhD, MD, JD, MD, the public health. Would this be something that could fit into a medical curriculum at that level, or do you think that you have to get down to finishing your residency or getting into kind of more of a knowledge system or base knowledge of medicine before you're able to really get thrown into a program like that?
Oh, I don't have a good answer for you. I mean, this is, once again, the problem that we're trying to solve, in that this is like fitting a circle into a square hole, you're sort of damned if you do either way. If you do it during residency, you can't really take a year off super easily. Right. If you have a research year, that's probably the best way to do it. But then you're in this awkward position if you end up starting an amazing company. What do you do then? Do you go with the company, or do you finish?
We're gonna follow your model and just
But I mean, I still practice, and that's, I'm super grateful with how all the timing worked out. But it's this is one of the big things that a lot of people reach out to me, and they're in training, about to enter training. At the end of their training, they're have some really exciting opportunity, and they're what do I do? And I don't know. And it's a case by case thing. But I think ideally, if you can finish your training and do this sort of thing, and do both to some extent, I think that is an ideal situation. It's really nice to be able to live in both worlds, but it's really hard to execute on that.
I had a question about if assuming, or if this takes off and you have like your ideal situation, how do you see this being implemented on a grander scale? I mean, is this part of an everyday residency, not every day, but into every resident type training program? Is there like an assessment test you have to pass before you graduate? I mean, how do you see that fitting into the surgical education that exists now?
I guess also just to add to that, so you can answer it in that same answer the same question, but the accreditation, I guess, as well.
Mm-hmm.
Like, how do you achieve accreditation with this? And I think that can piggyback onto what your question was.
Mm-hmm. Well, in terms of the ultimate vision, at the beginning of our talk together, I talked about how I was attracted to the mission-driven nature of working with children. And so I really wanted to bring that feeling to everyone at OSSO. And so we have our mission, which is to improve patient outcomes with better education and assessment, increase the adoption of higher value medical technologies to increase the consistency and quality of our procedures in healthcare, and then democratize access to surgical education all around the world. So, whether you're in New York or Los Angeles or Ethiopia or Tanzania, you should have access to the same quality and training opportunities across the board. Mm-hmm. And so that's something that we really believe in. And to accomplish that mission for us, we really want to get VR training and assessment to the 30 million healthcare professionals around the world that practice technical skills with patients. And that's anything from putting in an IV to doing complex robotic surgery. Mm-hmm. Now, in terms of this specific area we're focusing on, let's say training orthopedic residents, there are a couple of use cases where, clearly there is utility for, if you're starting a rotation, there are really two things that you should be thinking about. One is your learning curve with specific procedures, and the other one is something I call the trust curve. And so this is the idea that, if you're an attending and you have a resident or fellow coming in, you don't know them. You don't know how safe they are, what they know, what they don't know. And you spend actually a good number of cases getting a sense of that before you'll feel comfortable enough allowing them to get some reps in. Right. And so this can cause a pretty significant delay that actually increases based on the size of your program. So the less you're with a single person, the less comfortable they'll be with you. Mm-hmm. And so if you can, one, get yourself further along the learning curve, and then two, give objective evidence that you're trustworthy and move along the trust curve as well, it's really going to improve your experience with patients, right? So you're going to be able to do more sooner in terms of autonomy in the OR. So, if you're, R2 starting on joints, then, you want to be able to do end-to-end, total knee, uni, anterior, posterior hip, for example, and just be able to have that down pat, demonstrate that, and then come into the operating room. Now, a lot of the things we do in residency is kind of like one-off. So like you'll take call or be doing something here or there, and suddenly you're on a joint rotation and now you're doing complex spine trauma or something like that, and you haven't done that in a few years. Yeah. You just get pulled all sorts of directions. So
remember those
the ability to refresh yourself or get up to speed on something you may not have seen in a while or ever is really valuable. So instead of carrying netters around, you can carry around just this VR headset, which is about the same size, same weight, and just jump into the procedure. And hey, you got an open femur going, your chief wants something done very particularly, but he's too lazy to come in. He can jump into VR with you, walk you through the whole case, the setup, and then, the chief and the attending can come into the room and everything's really ready to go exactly how they wanted it. And there's not all the backtracking that often takes place in sort of the messy nature of, emergency surgery. Another issue that we have in our field is, in any field of where you're doing procedures that involve emergent situations, is low frequency, high urgency situations. And so, in my training, I had one experience where, as APC pelvis comes in, Gen Surg needs to do an X-lap and we need to do an X-fix. It's going to save this patient's life, right? One of the few situations, it's like where we have the opportunity, or I guess the risk of, someone's really life in our hands. And so, the attending that I was with really wasn't very comfortable doing it. I think it had been like 10 years since he had done it. And, one of my fellow trainees had just done a bunch randomly, on like a previous rotation. So she did it, save this patient's life, and I was just like, holy crap. that should never happen.
Yeah.
Like
Or you have
these are
the
things.
intern reading the technique guide to the attending physician. Scrub out, quick. You have to read to me exactly what's going on. I'll put it on YouTube.
Yeah.
Thanks.
Yeah, no, I mean, for real, like we've all been there, and these things, we all trained at stellar institutions, and it's just the reality of the challenges that we face when you have no idea what's coming through the door. And many people aren't really aware of the challenges that we deal with in terms of the sheer variability of what we deal with. One of the ways I try and illustrate this to people is I was at lunch with, my former chief had just become an attending. So he's like a new attending. We're at lunch. He gets a phone call. He's gone for 20 minutes, comes back and just looks different. I'm like, what's going on?
Yeah.
And he's like, what do you know about gorilla anatomy? I was like, okay, now you really have to tell me. He's like, that was the zoo. They said their gorilla needs surgery. His brother pushed him off the cliff because he was jealous because he was flirting with his girlfriend. And, they said we have to drive down there right now and operate. I'm like, well, what surgery do we need to do? He's like, I don't know. I said, what do you mean they don't know? It's like they can't get an x-ray without tranking it, and they can only trank it once, so it's like you have to get the x-ray and immediately do surgery. So we just need to be like standing by.
Yeah.
And so
this is ridiculous. I'm staying silent, but I'm anxious. Go ahead. Continue your story. This is a ridiculous story.
This is like trial by fire. This is pretty fascinating. Okay, keep going.
Wait, am I the only one who's had this experience?
Yeah.
So,
not on it. Go ahead.
Yeah, so I'm like, well, are we going to go? And he's like, hell yes. So we're in the room. There's like 50 people in there. There's like 500-pound gorilla with like a fire hose down its throat. And, it had subtrochanteric femur fracture. Like, we didn't have a nail that could fit it or some complication there, so we had to put a plate on, which is suboptimal. And, apparently, like, large animals wake up instantaneously from anesthesia and become very violent. So, anytime they would move a finger, the anesthesiologist would be like, everybody get out, you're going to die. And, like, you just, like, run for the door. So there were, like, 2 times where we had to evacuate. And then, finally, it was just like, close up. We like rush the gorilla down the hall, and everyone's like, move, move, move. And you like throw it into like its little room, close the door. And I mean, it was like the biggest adrenaline rush of our lives. Like, we're all like high-fiving and crying. And it was really interesting to me. I'm like, guys, we operate on human beings every day. I've never seen you this excited, just because it was so different. But I mean, that happened, and he's doing great, is my understanding. Last time I checked, but like
snap his plate immediately.
I know, right?
we had to switch out one screw. It just backed out.
I was thinking the same thing. I'm like,
oh yeah. I mean, I was like, oh yeah, just be a Jabari. Can you be toe touch weight bearing on the left side? Thank you.
Great.
So yeah, that was a fascinating experience. But I mean, obviously an extreme example, but I mean, we deal with stuff like that every week, right? It's just, it's something that you've never seen before. It's so extreme, so crazy. And, you're just kind of thrown into it, and maybe you're Googling something, or you have like some textbook that was useful like 30 years ago, but there's not a lot you can go on oftentimes.
Yeah. And yeah, you're right. And that happens to all of us. We'll all come across something, especially I talked to so many people who were in their first year of practice. Really, within the first 3 to 4 months, you'll get a case that I never saw this before.
It happens all the time. Or I haven't done this in 4 years. Let me just go and refresh through a book.
It happens to us all the time.
Watch a ViewMedi and try to, and these are people, and it's really nice to have some type of validated way to practice without having to get a cadaver lab or do something.
Yeah, because we have such a responsibility, right? So. I did want to pivot a little bit. I wanted to ask you a little bit about the actual technology, because one of the things that's important also in surgery is some of that tactile feedback. You don't always have to rely on it, but a lot of times, it's nice for us to have that tactile feedback. Are you working with any companies on any terms of like suits or gloves that give you some haptic feedback while you're doing a virtual case? Or
well, this is definitely the most common question we get. So what we're using is, right now we're using the Oculus Quest, and then we'll use what are called the Oculus Touch controllers.
Okay.
In these controllers are orthogonal kind of MEMS actuators that are, provide what are called cutaneous haptics. So haptics feedback has a few different categories. And so, your phone, like vibration, light touch, these are termed cutaneous haptics. And then there's another category of what people commonly refer to as force feedback. That's called kinesthetic haptics. And that comes in 2 varieties. One is grounded kinesthetic haptics and then ungrounded. So, if you're describing like a glove with an exoskeleton on it that stops your hands when you wrap around an object, that would be an ungrounded kinesthetic haptic feedback.
Okay.
Or, you may have seen this if you look at, sometimes you'll see like a stylus that's like on a desk and you hold this little pen and it kind of pushes back against you. That would be an example of grounded kinesthetic feedback.
Okay.
And so, in the early days, I definitely was thinking, I'm like, oh, haptics is so important for what we do. I want to have the very best haptics out there. So I kind of wanted to experience what the best haptics felt like. So I actually got a chance to demonstrate the Da Vinci surgical robot from Intuitive Surgical.
Okay.
And so I was like doing, some suturing and moving some rings around with this robot, which is really cool. It's not something we get to use often in ortho, so I highly recommend you try it out. And I turned to the rep and I was like, hey, the haptics on this feel incredible. Like, how did you guys do that? And he looked at me and goes, oh, there's no haptic feedback at all. I'm surprised you didn't know that. And so, I was a little embarrassed, but also like kind of astounded. I was like, well, I can feel this. And so I had this realization, maybe I didn't really understand haptics as much as I thought I did. And so, the sense of when you're using the Da Vinci is, there are different terms for it. I call it like phantom haptics, but I've also seen sense substitution or digital synesthesia. And the idea is that much like an optical illusion, your brain will actually fill in the gaps from something called tactile memory. So if you know what it should feel like, usually it will feel that way to you for the most part. So I thought that was really interesting.
That is so cool. That is so cool. Actually, it's true. I did have that experience with like that Beat Saber game, but anyway.
Huh. There you go. I mean, you must be using lightsabers to slice musical blocks all the time then.
Exactly.
And so the other thing is, surgical simulation isn't like a brand new field. Like, the idea of not training on patients has been around forever. What's new is, being able to use a commoditized gaming technology that's so effective and amazing. So I was like, well, surgical simulators of the past decade or so have utilized grounded kinesthetic feedback for some time, and it's pretty high quality. So I'm like, well, how much does it help? Because it's very expensive and it can break. And so you have to constantly like repair and maintain it. So when you look at meta-analyses of the vast majority of research, best case, it provides a little bit of skill transfer, but not clinically significant. The vast majority of studies show no benefit to including grounded kinesthetic haptic feedback to simulators. And then a small minority of studies actually show a negative training effect. And those authors attributed it to the haptics actually training them incorrectly. So it's almost as if you're training an NBA player on like a carnival basketball hoop, for example, was sort of the theory of why that turned out that way. And another thing is, do people even like this form of haptic feedback? And so there was a study where they took surgeons, they had two simulators. One had grounded kinesthetic haptics and one had no haptics at all. And they said, which of you think that haptics is the most important factor for a simulator to be successful? And it was 17 out of 20 surgeons said that haptic feedback was the most important feature to them. Then they had them try both simulators, and they were blinded, so they didn't know which was which. And then they asked the surgeons afterwards which simulator felt more realistic, and 18 out of 20 said the one with zero haptics.
Oh, interesting. Okay.
Yeah. So, and then one of the reasons that they attribute this is a phenomenon called the uncanny valley. Have you guys heard of this before?
Yeah.
So, the classic example is it's typically from like animation or animatronics, where if something is really realistic but not all the way there, it actually really freaks the human brain out. So if you've ever seen the movie The Polar Express or Final Fantasy Spirits Within, those are like classic examples of uncanny valley, where the whole movie you're just like, I feel very uncomfortable. I don't know why. And it's this phenomenon of uncanny valley. So what's really interesting is that if you show these sort of like higher kind of like hyperhaptic simulators, I don't really know what to call them, these kinesthetic haptic simulators to non-surgeons, they'll often say that it feels great because they don't know what it's supposed to feel like, right? They're not used to drilling into bone or cutting skin and things like that. So to them, they don't know what realistic is. But then when you show it to surgeons, it feels weird and very distracting. And so the reason why you see so many of these is that people who are not surgeons like get excited about it and show it to investors who aren't surgeons, and they get excited, and then they finally show it to surgeons. They're like, this isn't super great. So that's why there have been, like, for so many years, these things have been kind of floating around. So I wanted to, the advantages of, being able to use these controllers, which still have haptic feedback, even with cutaneous haptics, and, we can do really cool things. Like when you're drilling through bone, you can tell if it's cortical or trabecular bone. So you can actually feel the intramedullary space. You can kind of, one of the interesting things, how I knew we were on the right track is in the early days, we didn't have any haptics at all. Like there were no cutaneous haptics. And so, people would be hammering this tibial nail in, and they take it off and they turn to me and they go, "Hey, I don't know how you got the haptics. It feels so good, but that was awesome." And I was just like, that's so crazy. Like there were none, So I think there's a lot of research that needs to be done in this area. But I think at the end of the day, what we should be focused on is not what the training is like, but what the results are. And so I think that's the key thing, is how much skill transfer are you getting from a specific simulation? And, if it's for surgeons, if, you have to wear like a chicken suit or something, it's going to make you a better surgeon, I'll wear it, right? And so that's why I try and kind of like, there's a lot of thoughts and there's still a lot of open questions around the utility of specific kinds of haptic feedback. But at the end of the day, it's the overall skill transfer. And that's what we found with the way that we do surgical simulation with our platform, is it leads to, in this UCLA study, a 230% boost in surgical performance. And part of that is that you're practicing in virtual reality, you're getting the reps, but also you have some assessment. So like if you're reading a technique guide, you're watching a video, you're getting a lecture, at no point is someone checking that you're ready. You just proceed to the OR when you feel ready. And what you feel and what reality is often are very different things. And so that's the key part of OSSO that really differentiates from how we do training currently, is that you can get objective data that you are ready to perform certain parts of procedures.
Okay. So which institutions are currently using your technology?
So, we work with around 20 residency programs in the US and the UK. Some examples are like UCLA, Hospital for Special Surgery, or HSS to us.
Yeah.
A variety of leading academic medical centers are using OSSO VR, and then also a number of medical device companies use OSSO VR as well. So either instead of or in addition to courses, they'll train people with VR headsets, especially in the intra-COVID and post-COVID era. We're not going to be able to go to conferences anymore, and we're not going to be able to go to courses. I don't know about you guys. I don't know when really I'll ever feel comfortable going to, like, I'm like kind of sad about it. Academy is like my favorite event of the year, but
Virtual Academy.
it's hard to imagine going back to that anytime soon. So, but those are really important events for us, not only socially and politically, but, technically for training and getting exposure to new technologies and new techniques. So, being able to continue to improve our skills. And this is like, I think kind of, I'd love to hear your guys' thoughts, but I feel like the main way that we can continue to improve, post fellowship is through industry, right? It's industry that gives us more opportunities to train, some sort of oversight and connection with KOLs, and exposure to new technologies and techniques. Now, some people are very lucky and they work at an institution where there's good mentorship and like not a non-competitive atmosphere where people feel comfortable having other more senior attendings supervising and helping out. But like I feel like that's probably more of the exception, and that it's, once you're out, it feels like you're alone. And so that this industry provided training to me seems like a really critical resource that I hope we can maintain, so that we can continue to have postgraduate training opportunities.
I think we're continuously learning, and you need an avenue to do that. And I think the industry has the funds available to help us, and I feel there's easier access than trying to go back to an institution that you trained at, right? When, again, we're lifelong learners. And as orthopedic surgery in general, medicine in general continues to innovate, you have to keep up, or you're obsolete, right? Even in our field. So I think that in having close relationships with industry is important, as long as, I guess, we always have to not cross any lines, right?
Yeah.
So, but I don't know. I think that's just a realistic avenue for us to get our resources to continue learning. So.
Yeah. No, I think it's an incredible technology, and I think you're very much accurate in saying that it's really the exception to have like wonderful mentorship and feel like you're in this collegial space, like residency, where you're going over cases all the time and, well, what would you do here? What would you do there? And to have a feedback system where you're not getting your assessment by some patient's outcome, because, especially as young surgeons, whether you're well trained or come from Harvard, and you come into a situation where you're doing a new case, you don't want your assessment to be how they're doing postoperatively in 3 months. To get that feedback and practice ahead of time so that you give the patients the best outcome, which I think is what you've been saying all along, is to get that outcome driven benefit from this technology. And the COVID-19 issues is a huge thing. I mean, I've had 2 courses cancel already. You're not going to academy. This is cadaver labs. You're doing very small scale stuff where you don't always have funding to do something substantial like a cadaver lab per se, but you can virtually work with people all over the country and world to get the training or exposure that you need to feel like you're comfortable and you're taking care of patients well. And I think that's fantastic.
That's the silver lining of COVID. If we're going to find anything, I think there's going to be a lot more technological innovations because of this, right? And we need to be able to adapt to our current situations as it is. So, certainly applications like Zoom, or the technologies like Zoom and stuff, like telemedicine is definitely having its sort of heyday right now, and it's going to, I think, continue to. I think there's going to be more innovations in that, being able to deliver it in a better fashion, and without too many technical glitches, I think, like we're seeing now. But yeah, I think that is the one silver lining that I see anyway. I think that there's going to be a lot of ideas that come out of this time period, and hopefully, more disruptive and interesting ways that we can practice medicine, and in a way that kind of keeps up with what's coming down in the future.
I have a random question. Is this something like you can score and compete against your friends and across?
Oh, yeah.
Oh, yeah.
You're like, okay, I scored 2,040.
Yeah.
Like my total knee replacement. What'd you get? Like, I did it in 20 minutes. You did it in 15 minutes.
Or if you don't like pass like levels of failure, like you totally like failed that. Like,
yeah, it's interesting.
I got the top score, in whatever.
Yeah, you have to provide a way for people to be competitive without making people feel bad or embarrassing them, and so it's like it has to be all like couched very positively.
Yeah.
So for us, like all of our different rating scales are like some positive descriptor, like they range from basic to extra. But it's if you look at traditional surgical rating scales, it's kind of like super archaic. Like it's like it's unacceptable or like they're like really negative. It's like embarrassing to your mother, level 4. So it's trying to bring some of that to the modern age.
Oh, that's awesome. Funny. That's fantastic. Do you have any last words or anything that you want to impart to the audience?
Well, yeah, a couple of things. I mean, one, you guys were talking a little bit about the silver lining. I think, a lot of digital technologies are kind of having their, light of day and have, we're so lucky a lot of these technologies existed when all of this started happening. But, at the same time, we can be better positioned to integrate these technologies better and innovate more constructively. And so I think a couple of things that, I would like to see in terms of our contribution for OSSO, I think there are a couple of areas. One is streamlining medical and postgraduate education, especially for surgery. Like, if young people are looking at a career in surgery or like a career in technology, it's making less and less sense to get into the surgical world, which makes me super sad. But, who wants to spend 14, 17 years until you're an adult? And so, I think, really advocating for med schools to follow in the footsteps of NYU and at least being 3 years, maybe even the opportunity for a 2-year or more integrated medical degree to undergrad, I think are key. And I think through competency-based training, I think we could potentially shave a year off of residency, which has been shown in Canada. They've done some experimentation with this, which it can speed up training if you include more simulation and more assessment to let people out when they're ready and not just when they've been there for a certain period of time.
You're going to piss off all those old guys who work 200 hours a week?
Yeah.
Man, they're already pissed off about the work hour restrictions.
Oh, I know.
You guys are weak. You only work 80 hours a week. What's wrong with you?
Oh, yeah.
If I did it, you can do it,
Yeah, no, believe me, I got a lot of that.
I remember like those side eyes that you'd sometimes get if it's like sort of time to go home. Really?
God, that's my favorite thing. It's like, do you need anything else?
Yeah, exactly.
As a medical student, it's like there's like
I have to
translation. Please let me leave. I haven't seen my family in weeks.
Okay.
Oh yeah, we all have shared trauma. That's great.
Yes. Well, thank you so much, Justin.
Yeah.
This has been fantastic. It was so enjoyable talking to you about this.
I think you guys are doing an incredible thing. Like, keep up the good work and getting the word out there. But I think you guys will be very inspiring to a lot of physician innovators and healthcare innovators, and we'll get to see more solutions like this out there.
Okay. Well, okay. Thank you.
Well, thanks.
All right. Okay.